Hi,
It's great to see you. How are you doing, Jaquetta?
I'm good. How are you?
I am good. No, just getting in the fall spirit, I guess.
I'm I'm trying to get there. Not quite there yet.
I know. I totally get it. I'm like more of a summer girl, but I'm just trying to embrace it. But it's really good to see you. We saw each other back in September, and I know you were sharing with me about all your weight loss, which is amazing, and kind of wanting to get back into treatment and doing IVF with donor sperm. So I know we updated a whole bunch of testing, so I thought we could kind of go through all of that today and answer any questions that you have. But everything looks really good, which is great. And then we can kind of talk about next steps to move forward.
Okay.
Okay,
All right.
great. And how have your periods been? Because I know you have some irregularity in your cycles with the PCOS. Have you had a period recently?
I just had a period. Give me a second because I record all of them.
Okay, perfect.
I just had one on the 23rd.
Okay, great. 10, 23. And have they been coming somewhat every month or not necessarily?
So they've been coming every month. The length of them varies every month. So this month it was only like 2.5 days.
Oh, okay. Okay, of bleeding.
Yeah.
Okay.
So
That's no problem,
they've been coming every month, but the length of them it varies.
Okay. All right. Well, I'm glad they're coming every month. That's good.
Yeah.
Because I know in the past it was a little more variation than that, I think. So that's good to hear. And then, I know with all this testing you've been doing, we always like to get an idea about your egg count, your ovarian reserve, and that had always looked really good before. So we just wanted to update it. And it still looks really great, which is really good. So when we did the ultrasound, we looked at both your ovaries and we counted the number of little follicles that we see. And the reason that's helpful, of course, is that's kind of the pool of eggs that come to the surface every month that we try and then stimulate when you do IVF. And so we were able to see 25 little follicles, which is really good. I'm usually hoping that we'll see at least 10. I was really happy with that. And then for the hormone levels that we get, and again, you probably remember these from before, but we always get the AMH hormone level. That's a hormone that's produced by cells around the eggs. So so AMH is higher. That means a higher egg count. And I usually want to see the AMH around 1 or higher.
Okay.
And yours was 3, which was really great. 3.4. So that's excellent. That's good. Really good for your age. And then FSH is our final hormone that we look at. FSH is a hormone that's produced by the brain, kind of how the brain and the ovary are, talking to each other. And we like to see the FSH around 10 or less. If it's elevated, if it's higher than 10, that makes us think, the brain's having to work a little harder to stimulate the ovaries every month. But your level was normal. It was 8.6. So that looks really good. And so all those numbers were great. And then I know you did a whole bunch of other tests. We always get that infectious disease blood work. Our lab just requires that from everybody. So that was all negative as expected. That's the hepatitis, HIV, and syphilis testing. We screened you for diabetes. You did not have diabetes, which is great. We got thyroid function testing done. That was normal. We got some kidney function, all those kinds of things done. Those were normal. Your prolactin was normal. You were immune to rubella and varicella, which is great. That's German measles and chickenpox. You don't need any booster shots.
Yeah, I just recently had, about 2 years ago, I just recently had another measles, mumps, and the other one. I just, because I started working at the hospital. So they required that I get another one once I started. But I had it already. And then once I got the second one, I broke out into hive. So...
Oh no, I guess we'll have to add that as an allergy, but the good news is you are immune, so you don't need any more.
Right.
But that's awful. And then the only thing was your white blood cell count was a tiny bit low, not really low, but just a little low. So I told Maya we'd maybe just repeat that before we go through treatment. I don't know if you've done that yet, though. That maybe hasn't happened quite yet.
So I didn't do it. I went to Quest thinking you guys sent it to Quest, and y'all sent it to LabCorp. So.
Oh, I'm sorry, because you did your other labs at Quest, didn't you?
Yeah.
I'm so sorry. Oh, did Maya get that fixed for you, or
So,
not yet?
So not yet. I was going to message her today, because I was going to try to do it like after this appointment if she could send it over like to Quest.
I'll send her a message too. I mean, it never hurts if you message her as well, but I'll send her a message too. I'm so sorry that happened. That's so frustrating. I apologize. I think everything's fine. I'm not too worried about it, but I just wanted to make sure. Because otherwise, you've done all your testing. I know you did the saline sonogram. So we always like to just make sure that the cavity of the uterus, kind of the inside, looks normal, that we don't see any polyps or fibroids or anything growing on the inside of the uterus. And that looked really good. Cavity looked totally clear. You have a couple little tiny fibroids, but they're either in the muscle of the uterus or on kind of the outer part of the uterus. And those aren't as worrisome for pregnancy. It's really the ones, either if someone has a really big fibroid and it's kind of pushing on things, which you don't, which is good, or if a fibroid's in the cavity of the uterus, where the embryo would be trying to implant, that's more problematic. But otherwise, we know fibroids are really common. It's very normal to see little tiny fibroids in other parts of the uterus. So the good news is it doesn't look like there's anything that's impacting the cavity. I don't think you need to have any surgery, which is good.
Okay, great. That was my concern because I had them in my uterine cavity once before, so that was like I had polyps and fibroids, so that was like my big concern. So when I got the email saying it wasn't, I was like, okay, good.
Yeah, I was really happy to see that too, because sometimes on the standard ultrasound where we're looking at the egg count, it's a little hard to tell. That's why we always do that saline ultrasound where we actually put the water in there and then can get a better idea of the cavity. But yeah, I think we're in the clear. I don't think you're going to need to have any surgical procedure on your fibroids right now, which is really good.
Okay.
And then let's see. Oh, and I did get the clearance letter from your bariatric surgeon. I know you had said they were happy with you moving forward once it had been a year, and they kind of echoed that in their letter. So that's great. So we're all set. So I think barring just repeating that blood test, which I apologize about, I'll send Maya a note to resend it to Quest. I think we're good to go, and we'd be ready to get started, like potentially as early as with your next period if you wanted.
Oh, Lord.
Timeline that you'd like to move forward, or only if you want. I definitely don't want to pick you. If you're like thinking 2025, that's totally fine.
No. I want to start as soon as possible because these pains are like they are coming and they are bad, and I feel like they're getting worse as time moves on. So the earlier I can start, the better. I'm just trying to have these babies so I can get rid of this uterus and hopefully the pain as well.
Yeah. I hope so. No, I remember that, so I'm sure it is continuing to be really bad with each year periods. Is it kind of bad all the time though? Do you just
it's bad all the time. With periods, it's not as bad, but without periods, I'm like slumped over, waking up out of my sleep. But like when my cycles start, like they bad, but not as bad as when I'm on my period, if that makes sense.
Yeah, no, it does. Oh gosh.
So
well, then you're probably disappointed your period's only 2 days. But that's like the best time. Like I feel disappointed.
Right. So and it's like crazy because I be sitting here and I'm at work and I'm in pain trying to talk to patients, and I do anything to like try to help myself. Like warm compresses don't work no more. I used to sit in like hot baths. That don't work anymore. Like I guess my body got immune to everything.
So I'm so sorry, but yeah, I agree. We just want to get you your baby or babies, depending on what you want. Were you thinking one baby or were you thinking a couple?
I'm thinking a couple.
Okay.
If we could get 2 babies the first shot, so I can get rid of this uterus, it'd be amazing. Like I'm okay with most.
I know. You know they're only gonna let me finish for 1.
Okay.
That's kind of a strict rule. So now the thing is, we could get lucky for you. I mean, there is still the chance an embryo splits in 2 and becomes identical twins. It's like a 1 to 2% chance, but yeah, they're pretty strict. Even nationally, there's guidelines that we really recommend just transferring 1 at a time. So that is what I would recommend for you, but I know that we want to move forward as soon as possible. And I mean, I'm really hoping that when you're pregnant, you'll get a little relief. I don't know if that'll be the case, but I'm hoping. And then I think we could just, if you wanted to have another baby after that, like try to move forward as soon as was safe. Because I agree. I think for your quality of life, I know you want to have a hysterectomy like sooner rather than later.
Yeah. Yeah, because it's like, I don't want to go outside. I don't want to do anything, just like ball up in my bed.
I'm so sorry.
So,
has anyone ever like really found a reason? Like, do they think it's endometriosis or think it's like adenomyosis or just pelvic congestion or?
So I've done a lot of testing, seen a lot of doctors. They say it's because of the fibroids, it's because of PCOS, it's because of endometriosis. And then I spoke to another doctor at Franklin Square Hospital, and she did testing and everything, and she was just like, I don't know what's going on. She said the best thing that I can tell you is that you would need a hysterectomy because the pain is going to get worse. And she was literally right, because since that appointment, my pain has gotten worse over the years.
Oh, gosh. So. Well, yeah, let's move forward as soon as we can. Try to get you your baby. Because, I'm hopeful, fingers crossed. I mean, for some people, their pain does get better when they're pregnant. So I'm hoping that's the case for you. That would be nice. That would be a good 9 months.
Absolutely.
When we think about IVF, like I said, I think we could start with your next period. So maybe that would be sort of end of November, whenever it comes.
Mm-hmm.
Now we are open. If it happens to come around Thanksgiving, we're open. So don't worry about that. I don't know if you have any travel plans for Thanksgiving, or will you be local?
I'm going to be home. Everybody. So Thanksgiving, we all come to my mom's house. For Christmas, we all spread out. But Thanksgiving, we are all here in the city.
Excellent. Okay, good. Because I was going to say, I know now we're kind of getting close to the holidays, but we are open, so that will work perfect. And what we can do is probably plan to start with your next period. Now, the process of IVF, I can't remember if we've talked about it too much before, but the goal, of course, is for us to get as many of your follicles to grow as we can. Mm-hmm. And the way that we do that is we have you take injectable hormone medication that's basically just a man-made version of FSH, or follicle stimulating hormone, which is what your body makes. Okay. Now, your body makes enough FSH, to grow 1 egg every month, and your FSH levels are totally normal. But, you have 25 follicles, and ideally we want as many of those as we can to safely grow. Now, we know realistically probably not every single follicle is going to grow, but we have a little prediction tool where we can kind of estimate how many eggs we're going to get based on, your age and your egg count, based on hormones and ultrasounds and everything. And it was estimating, my little prediction tool was estimating that you get around 17 eggs, which is really good. I would love it if we were in that range. The average number of eggs we get is 10. So anytime we can get above 10, I'm always happy with that. And then when we look at the eggs under the microscope, usually about 70% or so of those eggs would be mature. So if we got, around 17 plus or minus, maybe we'd have like 12 or 13 mature eggs. And then we would fertilize those eggs with your donor sperm. Now, is the donor sperm at the sperm bank, or is it at Shady Grove already? I couldn't remember.
It's at the sperm bank. I did not purchase it yet. I plan on purchasing the sperm. I wanted to see like what was our timeline, so I'll know like when to purchase it. Because I'm actually still looking at like a few. I don't know. Because the one that I was going to get, he's actually out of vials, and I didn't realize that it was a difference between like IUI vials and IVF vials, and
right.
So
yeah, no, and the good news is actually for IVF you should be able to use any kind of sperm. Which is nice. Like the differences are more the concentration of the sperm.
Mm-hmm.
And so like IUI is going to have a higher number, because for IUI, you might remember we want like, millions of sperm.
Right.
For IVF, we only need 1 sperm for each egg. And so for that, we don't need quite as high a concentration. So that's usually the biggest difference. So if you happen to purchase a vial of like IUI ready sperm, that would be okay. You just wouldn't want, if you were doing an IUI, you wouldn't want to get IVF ready sperm, because it's going to be a lower concentration.
Okay, so I didn't know that. Okay, so I can go ahead and purchase the one that I wanted then, because I thought it was like a specific vow that I had to have. So I can go ahead and purchase it then.
Yep. Yep. And is that the same donor that you used before, or is it a different one?
It's a different one. The donor that I used before, he don't have any vows left.
No, that's okay. Because then we'll have to do that gene screen consultation. So I'll have Maya help you get that set up to like review the donor and your genetics.
Okay. Yep. I still have my well, I tried to look for it, but I still remember that I am positive for nephrotic syndrome.
Oh, nephrotic.
Yes, nephrotic syndrome. I did know that. That's the only thing that came up. So I do know to look out for that.
Yep. Perfect. And actually, sorry, can I be back in 1 second? I just think I have to do one thing really quickly for one of my nurses. I'll be right back if that's okay. So sorry.
Yes, it's okay.
Okay. Okay. Oh, I'm back. I'm so sorry about that.
It's okay.
She just sent me a message really quick on my phone. I was like, I gotta deal with that real quick, but we're good. So yeah, I think the good news is it does not have to be IVF ready sperm. IUI would be okay. And then I think if it's a different donor than what you used before, they'll have to have you meet with the genetic counselor. So we'll set that up.
Okay.
I'm sorry. I know it's a little bit annoying, but
it's okay. It's okay.
It require that, so we'll get that set up. We got some time since I know your period just came like a week ago or so. We have a little time to get that all coordinated. And then otherwise, Maya will help you order all your medicines and everything. And usually you're on 2 hormone shots a day.
Okay.
So 2 shots to kind of keep the eggs growing. And usually the average amount of time that you're taking the injections, I usually tell people is like 10 to 14 days. So it's usually like a 2-week process to kind of mentally prepare yourself for the injections. And usually you're taking 2 shots a day during that time. And then at some point we will add a 3rd hormone shot in. And that 3rd shot, so the first 2 are to grow the eggs. The 3rd one is to prevent your body from ovulating. And that's called an antagonist. And that's one of the differences. I think you did the donor insemination cycle before. And, with that, we're like looking for you to ovulate. But with IVF, we don't want you to ovulate, because if you ovulate, that means, you release all the eggs, and then our cycle is spoiled. Okay. And so that's why you're on that 3rd shot. And the shots are going to be kind of like the Avidril shot. When you did your donor insemination, did you do an Avidril trigger shot?
Yes.
Does that sound familiar?
Mm-hmm.
Okay, so yeah, it'll be similar to that, where you just pinch a little skin on your belly, you have the very tiny needle, and you inject yourself with the hormone medicine. And then what we'll be doing is we'll be bringing you in every couple days in order to assess how the follicles are growing. So we do an ultrasound every time you come in. And then we also check estrogen levels, because each little egg is going to be producing estrogen.
Okay.
And so we want to kind of get an assessment that helps us, determine if we need to go up or down with your medicine dosage or make any adjustments. And then, like I said, probably 10 to 14 days of shots. Once we get to the point where we've got as many, good-sized follicles as we think we can get, we'll have you take your final shot, which is called a trigger shot. And we just use a little different medication than with the IUI. That was probably Avidril when you did the insemination. Mm-hmm. This time it's usually a medicine called Lupron. And Lupron is a medicine that kind of gets the eggs to mature, gets them ready for the egg retrieval, and then also drops your hormone levels, pretty quickly after the procedure, because you are hopefully going to grow a really good number of eggs, so you may have a little bit of an elevated estrogen level, which is okay.
Okay.
But that medicine kind of helps it decline afterwards, which is good.
Okay.
And then we would fertilize the eggs with the donor sperm. And then my question was, I couldn't remember if we talked about this before. There's different options when we get to the point of the embryos. So one option is to do what we call a fresh embryo transfer, and that means 5 days after your egg retrieval, we put our best embryo back inside the uterus. That's called a fresh transfer. And then, freeze any other good quality embryos that we had in addition to that one that was transferred. So that's one option. Now, if we wanted to do that option, that's perfect. I'll make a note of that. But we always have that as sort of a tentative plan because there's a couple of reasons why we might not want to do a fresh transfer. One is if you are just not feeling very well after your retrieval. I know you already have like a lot of pain in the pelvic area. So if you're just like, oh my gosh, I feel even worse than normal, like I don't know if this is the right environment or I want to get pregnant. Maybe I want to like let my body have a period, kind of reset, try again. That's always fine with me. The other thing is we always are looking at hormone levels. So we're going to be monitoring your estrogen, like I mentioned, and estrogen is routinely in the thousands during an IVF cycle, but if your estrogen gets to be like 4,000, 5,000, 6,000, that's okay in the sense that means there's probably a lot of eggs growing, which is good.
Okay.
But that's not really like the optimal environment to get pregnant. Pregnancy rates are not as high when estrogen is that high. Plus, that puts you at risk for something called hyperstimulation, which is kind of where people feel sick after the egg retrieval and an embryo transfer. Sometimes they even like have some fluid that accumulates in their abdomen. Sometimes they need to be on blood thinning medicines, and I don't want to put you in that situation. So if we felt like the response was really high, which again is good, and that means hopefully we're going to get a lot of eggs, it may mean that we just want to let you get a period, let your body kind of reset, and then plan on a transfer like with the following period.
Okay.
Otherwise, the other thing we look at is progesterone. So that we can't really control, but your progesterone kind of creeps up a lot of times towards the end of the IVF cycle. And if it crosses a certain threshold, we have some good data that shows pregnancy success rates are not as high if the progesterone is elevated, just because that means the lining is kind of out of sync with the embryo. So if that was the case, then I would also recommend that we freeze the embryos and do a frozen transfer.
Okay.
Now the other thing, because you and I are about the same age, I guess I'm 38 now, but we're about the same age. And we know as we get into our kind of mid to later 30s, we know that there's a higher chance of miscarriage, unfortunately, and that's usually due to chromosome abnormalities in our embryos. That's just due to like egg quality issues that we have no control over. It just has to do with our age. So one of the things that we could also do with your embryos, if you were freezing your embryos, is we could do a little biopsy on each embryo, and that's called testing the embryo for PGT, or pre-implantation genetic testing, which looks at the chromosomes of each embryo. Because at 37, usually about half of your embryos will be chromosomally normal, statistically, and about half will be abnormal. But the tough thing is sometimes the abnormal embryos look really good under the microscope. They have really high gradings, but sometimes they just aren't genetically normal, and that may mean that they don't implant at all, or it might mean that you get pregnant but you have a miscarriage, and obviously we don't want you to be in that situation. So there's no way to 100% prevent miscarriage, but one of the biggest reasons is genetic abnormalities. So sometimes people will plan to test their embryos for the chromosomes and then kind of get a report back that kind of looks at all the embryos we sent and lets you know, are they euploid, which is chromosomally normal, or aneuploid, which is abnormal. And then, of course, we wouldn't use the abnormal ones, but any that were genetically normal, we have about a 55% chance that you have a live birth if you transfer a normal embryo. Otherwise, if you transfer an embryo that doesn't have genetic testing, it's like a 40% chance you get pregnant, so it's still really good.
Okay.
It just is a little bit higher if you have that confirmation that the embryo is normal, and that testing is 98% accurate, so it's pretty good.
Okay. So do you know if the PGT testing is included in my insurance, or would I have to speak to the financial counselor about that?
Good question. Now, I would say for the majority of people, it's not. I will have Marissa talk with you. What kind of insurance do you have? Let me see if I can tell.
I have Aetna. She sent me,
Aetna.
I always get the messages late at night so I can't call.
I wonder if she's working at night. She's just said, I do a lot of work at night too, so maybe she is. But yeah, I think you have Aetna. I would say, I don't know if I'll be able to tell. Let me take a quick peek. I will definitely defer to her for sure. I would say my average patient, even if IVF is covered, they don't usually cover PGT. And let's see, it consists of two components. Okay, it says I'll have her check. So it says coverage is subject to plan guidelines and or exclusions. Please contact your insurance carrier. So I guess we could ask, and then so that doesn't say no, but it also doesn't say yes.
Right.
So I think we'll
That's what I was looking at last night when I looked at it, and I'm like, okay, everything else is saying yes and 50% copay, like,
right.
But this is not saying either.
So. Oh, that's like very nondescript. I mean, at least they're not just saying flat out no, I guess, but I don't know. I'll have her check, because I know, I think if you have to be out of pocket, now never quote me on exact dollars, because I don't want to tell you the wrong thing, but there's kind of two charges when we do the PGT. So one of them is our lab doing sort of the labor of the biopsy, where they are biopsying a couple cells from each embryo. And I think it's about $2,500, give or take. Now that's whether we biopsy one embryo or 20 embryos. So I think it's just a flat fee. And then there's also kind of a flat fee to do the genetic testing. Now I think, unless Aetna, like if they cover it and they say we only cover, lab A, then obviously we're going to send the embryos to lab A. But if they don't cover it, or if they don't have a preference where the embryos go, we usually send them to this company called Luminary Genetics. And what they have is kind of nice. I think from the way I understand it, it's like a flat fee until you have a baby. So like my hope is that you only have to do IVF once, like as in the sense of the stimulation and the egg retrieval and everything. My hope is that only happens once. But if you had to do it a second time, I think the fee that you pay to them is like, I don't think you have to pay that again, if that makes sense, until you have a baby. Like I think if you had to go through IVF 2 times, it's just that flat fee. And I think that's about $2,000 for the genetic testing results to be kind of performed. Okay. So I will definitely have Marissa give you the actual numbers. Those are just kind of ballparks from what I understand, but I think that's fairly accurate. And I think, the thing is, we are kind of on the bubble, I would say, like in our age. I think the studies kind of show that PGT is helpful in, decreasing miscarriage and improving live birth rate once we get to be about 37 or 38. So I certainly would recommend thinking about it. But I think if you're looking and you're like, I have coverage for all these other aspects of treatment, but not for this, and it's really not affordable at this point, I totally understand. It's not something you have to do, but if insurance covers it, certainly I would think about it. And or if you're like, I think I would just prefer to do this, to try to minimize the risk of loss and that kind of thing, I'm certainly supportive of that. Okay.
Yep. I was looking into doing that because, like you said, I want to give myself the best chances and the best outcome. Yeah. So I'll figure it out.
Perfect. And then, you may have read when you were looking at it, there's the main purpose is, decreasing miscarriage. But we also, if you wanted, some people want it to be a surprise, but if you were like, I'd be curious if I had male or female embryos, we can give you that information, because the genetic testing company does look at that, because they want to make sure the sex chromosomes are normal as well. So you can also get that information when you get the PGT results.
Okay, I did want to do that.
Okay, perfect.
Yeah, yes. So yes, if my insurance paid for it, but if not, I'll get the money to do that.
Yeah, I mean, I think I would do it if I was you, but again, it is expensive,
because like I said, I want to maximize my chances. So
I agree. I want to get you pregnant as soon as possible, so hopefully your pain gets better, and then that sounds good to me. Well, what questions do you have on the process? Anything I can answer for you?
So how long is the process altogether, like from start to finish?
Oh, great question. So let's say we start when you get your next period, and let's say that comes in the end of November, something like that. You would call Maya when you get your period, and I think we'll probably just bring you in for kind of a straight start with your period. So you'd call her, you call it day 1, or if it's the weekend, just call the office. Call it day 1. We usually bring you in on day 2 and do kind of a baseline ultrasound. And then if everything looks good, you can start your medicine. And then usually the medicine's about 10 to 14 days. So give or take about 2 weeks. So I don't know, let me look at a calendar. So let's just say your period comes exactly on November 23rd. It doesn't matter if it isn't exactly like that, but let's say it did. So then you'd come in on the 24th, you'd start your medicine that night, and then let's see, the 4th, 1, 2. So maybe you take your last injection of medicine, like, I don't know, on the 7th or 8th of December, something like that.
Okay.
And then you have your retrieval 2 days later. So the retrieval is kind of like with the IUI, where you take your trigger shot and 2 days later you have the IUI. Kind of like that. Trigger shot, 2 days later you have your egg retrieval.
Okay.
So let's see, maybe that would be on like the 9th or 10th of December. And then after that, if we're doing the genetic testing, you stop all your medicines at that point. You could probably anticipate getting a period about a week later. In the meantime, we will be fertilizing the embryo. So on the day after your egg retrieval, we know how many fertilizing eggs. Sorry, we know how many eggs fertilized the day after your retrieval, and we'll let you know that. And then a week later, we would know how many embryos we had to send and to biopsy and send for genetic testing. So we keep the actual embryo here on site at Shady Grove. We send the little biopsy, which is like 5 cells, to a genetic testing company.
Okay.
And then they do analysis. And then the analysis usually takes about 3 weeks. So let me look back at my schedule here. So maybe that brings us to right around New Year's or so, give or take.
Okay.
That we have the results back. Oh shoot, sorry, I was looking at a October calendar. Where was I? No, December. Okay, 1, 2, 3. Yeah, around New Year's.
Okay.
And then at that point, we could get started with an embryo transfer. Our lab does shut down briefly between sort of the Christmas and New Year's holidays. We have this mandatory deep cleaning that we have to do every year, and we just can't have like embryos in the incubator while we do that. But I actually think that timing would work out pretty well, because you'd probably get your genetic testing report somewhere around New Year's, and then we could plan to move forward with the embryo transfer in January if that worked.
Okay.
Now, the only little caveat to that, and Marissa can help us, is sometimes even if you keep the exact same insurance, like even if you're still with Aetna, they have to kind of authorize you, I guess, for IVF treatment. So that would be the only thing that I think might delay us a little bit, is usually that has to get done like January 1st or whatever. It has to get reauthorized. But I don't know, every once in a while someone's policy is different and the reauthorization happens at a different time. But Marissa can kind of let you know if that would be the case, because realistically then we might be like a couple weeks into January before we get our authorization.
Okay, I think mine will be a little after January, because I recently just picked up this insurance because I dropped one of my previous insurance. So I just got this one like in August.
Okay.
So I think mine will be a little later, if I'm not mistaken.
Okay. Yeah, I mean that would be great, because then we'd be able to move forward right away in January. So. Okay, so you're looking. Timing would work.
So January will be an estimate time.
I think so. Again, just depending on the insurance authorization, double check with Marissa about that, because she may have some information. But yeah, that's what I would think. So probably having the retrieval like early December, if we start with your November period, and then genetic testing results back by end of December, and then moving forward hopefully in January. Fingers crossed, unless there's a insurance issue.
Okay. I do have another question. Hold up. I gotta find it.
Yeah, no problem.
Because you answered a lot of them.
Oh, good.
Oh, man. I don't know. I think you answered all of them. Oh, is there any supplements that you recommend that I take now?
Excellent question. So what do you take right now? Are you on like a prenatal vitamin yet, or should we add that in?
I'm on a prenatal vitamin. I take vitamin D. I take iron pill.
Oh, perfect.
Yep. I take B12.
Okay.
Daily.
Awesome. So that's good. So there's like kind of 3 things usually, and you're already on 2 of them, which is great. So definitely being on a prenatal. So I definitely recommend staying on that. Also, the extra vitamin D is helpful, especially heading into winter. So that's good. The other thing that I might add, there was just a recent study that came out pretty recently looking at CoQ10. Have you heard of CoQ10?
I have, and everybody was talking about it, but I wasn't sure.
Yes, that one I would start. And the study, so previously I would say there were a fair number of studies, but a lot were in, animals or tiny human studies or something, but
Mm-hmm.
there was a bigger study recently that did show some benefit with being on kind of high doses of CoQ10 for like egg yield, kind of egg number, and also egg quality with IVF. So yes, I think actually if you started CoQ10 now, that would be perfect, because that gives you about a month of taking it, and then you can take it through your IVF cycle too. But the study that was done showed that taking 600 milligrams of CoQ10 a day was beneficial. So you can, when you purchase it, you can see what kind of milligram it is. But I think in the study they took 200 milligrams 3 times a day. I know it's kind of hard to remember taking medicine 3 times a day, so I don't think there's any problem if you took it twice a day, or divided the dose a little differently. But yeah, 600 milligrams is kind of what we're recommending as of pretty recently. So yeah, I don't see any downside to taking that, aside from, of course, the cost of just taking, purchasing one more supplement. But I can have Maya send you the information on a couple different options for like taking the CoQ10, but you could also look on Amazon, or look at Target or Walmart or wherever you do your normal shopping, because
I was going to go to Target.
I know, I grew up in Minnesota, which is where Target originated, so I'm definitely a Target girl myself. I agree. But yeah, I think you're already on the other 2 things that I would recommend, which is the prenatal and the vitamin D. So yeah, I think adding in the CoQ10, like starting that in the next couple of days, that way it's in your system. I think that sounds perfect.
Okay. So is it anything that you recommend that I stay away from, like as far as like foods, beverages, like?
Good question. Not too much. I mean, I think there's kind of a limited data, of course, as with most things on nutrition, but probably the best is just, trying to eat as healthy as you can, eating more kind of whole foods, more, complex carbohydrates, fruits, vegetables, lean meats or lean proteins. If you don't eat meat, that's fine. But if you do, probably minimizing like red meat, eating more kind of leaner protein sources, minimizing, processed food and that kind of thing. And then, I don't think you're a smoker, so that's not an issue, but I wouldn't smoke. I think if you drink alcohol, I think that's okay. I would just keep it in moderation and not, around the egg retrieval, obviously, because you're getting sedation. But other than that, I mean, those are the normal, kind of all the normal healthy things that we try to do. And then, as far as exercise, around the time of the egg retrieval, once you get like a couple days into your injections, you're going to want to really pull back on exercise. Because we worry, and obviously exercise is healthy, but during the stimulation, what's going to happen is your ovaries are going to be growing because you have a lot of nice follicles. So your ovaries are going to get bigger. They're like the size of a walnut or something normally, and they're going to get, decent size with this process. And so what we want is, we don't want you to be in a situation where you're like jumping or running or something and your ovary could twist on itself. That's called ovarian torsion, and it's a surgical emergency. It's very rare, so I don't want you to worry about it too much, but that's why we just don't recommend. I mean, you can walk, of course, for exercise. You can do, I don't know, you could probably do like a little bit of yoga, as long as you're not going upside down, but you just don't want to be like running or jumping or, anything kind of too, I don't know, can't think of a good word.
Too strenuous.
Keep it a little more calm. Yeah, too strenuous. You don't want to do anything. I don't know why my words just all like flew out of my head right there, but yeah, you just want to be a little more like calm with your exercise. But I don't want you to worry like walking up and down the stairs or anything. That's not a problem. You just don't want to be doing anything that's really going to jostle the ovaries, because when they're bigger, they're a little more prone to like twist, which is, again, not common at all. But
so is it a period of time that I should be expecting to be like off work so I can notify my job? Like,
good question. Honestly, I would say most people are able to work through this whole process. So even remind me, how much like lifting or things do you do at work?
I sit right here all day.
Excellent. Okay, good. I was gonna say, I didn't think that you were like lifting a bunch, but if you were, we can always give you a note or something. But so yeah, I think the only time for sure that you're gonna want to be off is the day of your egg retrieval, because you will be getting sedation medicine. So I definitely think you'll want the day of the retrieval totally off. Now, it's always hard to know because we don't know exactly what day that's going to be, but as we get closer, we'll have a little more understanding, and Maya will give you a calendar that'll kind of give you like a tentative, window of time where it could fall. So we'll at least be able to give you an idea. So I would say the day of the procedure off. Now, if I would say most people, especially if they work like from home, or don't have to be up and moving too much, a lot of people are okay working the day after their retrieval, especially if there is a little flexibility. Usually the day of the retrieval is probably the most uncomfortable. Sometimes the day after the retrieval can still be a little bit uncomfortable too. So some people do like having that day off as well, but I think a lot of my patients do end up going back to work and kind of doing their normal thing the following day, just probably with a little bit of Tylenol or something.
Okay, so even if I'm uncomfortable, my bed is right here. I can.
Exactly. Yeah, I bet it'd be okay to work the next day. I mean, the good news is the risk of complications is really low. Like, where you'd really be hurting, that's pretty low. It's more like, you already have pretty bad pain. So I guess I don't even really know what to equate it to. What I tell people who have sort of average period pain and things is like, it's kind of like a bad period is what it feels like afterwards. So it's hard to know for you, like, is it going to feel just normal for you since you already have really bad pain? Is it going to feel worse? Are you actually going to say, this actually isn't too big a deal considering what I'm normally used to? So it's a little tricky to know, but most people are able to manage with over-the-counter medicine like Tylenol after their retrieval. But I mean, just knowing that you have a little higher pain at baseline, if you felt like you needed a stronger pain medicine, I would want you to just call and let us know, because most people are okay without it. But I know you're a little different situation, just knowing how much pain you kind of have to deal with normally.
Okay. All right. Everything sounds great.
I'm excited. This is so cool.
I'm excited too.
Wow. So that's awesome. It was great seeing you today, and I'll let Maya know. I'm going to send her a message right now, actually, about the Quest.
Okay.
So I'm sorry about that. But I'll put in a protocol so you'll hear from Maya and Marissa in the next couple of days. They'll let you, kind of start getting ready for this in about a month or so. We'll definitely get clarification from Marissa about like what Aetna does and doesn't cover. So my suspicion is they probably don't cover PGT, but it is a little ambiguous the way that they word it. So we'll try to figure that out.
Yep. Even like I said, even if it don't cover it, I'm an artist and I sell my art and stuff, so I'll get it.
Okay. Excellent. No, that sounds perfect. And if you need anything or if you have any other questions that come up, just let me know, of course. But otherwise, we'll start getting things moving forward.
Okay, so if it's possible, can you ask Maya to send all of my lab stuff to Quest, because LabCorp is just always so busy, and I don't want to be off work that long. So if I can get everything through Quest, because there's nobody ever in that building.
Yeah, no problem. I will send her a message right as soon as we're done.
Okay, thank you so much.
You're welcome. It was really good seeing you.
It was good seeing you as well.
All right, talk to you later. Have a good, enjoy Halloween. I don't know if you're celebrating Halloween tomorrow, but
I want to, but I'm not.
That's okay.
Bye.
All right, see you later. Bye.